Very good morning, everyone. Uh, I'm going to present a complicated case of uh, uh, retinal detachment, which was post-trauma. A 17-year-old male uh, came to me with blunt trauma to his eye uh, uh, from 10 days, and then patient had partial retinal detachment. I asked him with it was macula on. I asked him to do surgery, and patient was not ready for that. And then patient left, and patient came back to me after 3 months with some uveitis, low IOP, and with total retinal detachment. So I'm showing you the surgery in front of this stalwart. This surgery might not be that impressive, but I'll try to show it. Here, as we can see, IOP was quite less, and vitreous was quite fibrotic, as we can see here. I started doing anterior vitrectomy here. It was a kind of bad day for me. Like this patient, uh, at examination, it was looking like a difficult case, but when I started the surgery, it became more and more complicated. Like I'm doing first anterior vitrectomy here, like whatever fibrotic turbid vitreous was there, I was trying to remove it. I kept on doing anterior vitrectomy, and suddenly I am seeing a change of glow. So as you can see here, I have kept it a little bit slow here. So this is change of glow, as I can see. I'm trying to pull the cutter back, and meanwhile, as we can see, there's a total choroidal detachment we can see here. And I just came out. I tried to push the infusion inside. If I can see the tip, I was not able to see. I changed the tip to the superior port then, and I removed the trocar from that part, and I did put trocar on superior side again, which part I felt it was directly going into the vitreous cavity. I confirmed it. Then again I started the vitrectomy. As you can see here, here also it was stuck. Even the superior one, that was also going below that. So I kept near the limbus. Before it was 4 millimeter. Then I went around to 3 millimeter on this port, and finally it was inside. I started the vitrectomy again. I felt now everything is good. I started doing vitrectomy. Things were looking good. The RD was the routine surgery. I felt now it will be the routine thing. So the routine vitrectomy I was doing, some places as I was able to see some choroidals were there, but I was not bothered about it, that it will drain out by itself later on. So air fluid exchange was done. Here, as we can see, one choroidal was there. I did retinotomy. I uh, removed the subretinal fluid. Once retina was settled, I felt the surgery is kind of almost over. There won't be much of the issues. As we can see, one choroidal detachment was left, and I was not touching it because it was quite posterior. I started doing laser, and I did almost 360-degree laser uh, around the hole, as well as 360-degree laser also was done. Almost when I completed laser, I felt that I should do cryo in periphery. due to the some of the retinal holes in periphery. I started doing cryo in periphery. Due to phakic lens, I was not able to go with the laser. As we can see here, I saw some of the retinal dialysis at this part, and suddenly, as I am seeing here, due to the infusion upside there was a bubble below the retina, and it was a kind of bad day going on. I felt I should do everything clearly, and I tried to push this bubble out from the same retinal dialysis. And as I was trying to do that, and suddenly, like I pushed it like that. Actually, it's a 3D video, so here it was not seen, but on other another part it was seen. It was total ballooning was done. So then I put PFCL. Luckily, with the PFCL, this went off, and even one choroidal detachment was there on the side. That also went off. Finally, in the end, everything was good, and I did PFCL silicone oil exchange. I did even laser again to some of the part which I felt which was not proper there. So I removed it again, and finally the retina got settled. PFCL was removed, silicone oil was put, suturing was done at all the ports. This retina is totally attached now, and this is the final picture right now. So retina is totally on, and patient's vision is around 636 right now. Thank you.
Thank you. The purpose of this course is usually we give textbook cases, ideal cases, simple fixes, and not infrequently, despite the best of intentions and best of skills, things go wrong. Could I invite our young member expert to maybe give some expert comments on what do you think, what went wrong, and what are the great things he did, and how else it could have been fixed? Kindly introduce yourself.
Thank you. I'm Dr. Sangeet Mittal. I'm a VR surgeon practicing in Jalandhar, Punjab. It was a nicely managed case. I think you did your best. A few things that I would have done differently is like if the cannula is going inside or in the suprachoroidal space, again and again, I would not have hesitated using a 6 mm cannula in this case. Though the patient was phakic, but when you put the cannula, 6 mm cannula, and you don't manipulate it too much, it won't cause cataract, right? So one thing was that. Second thing was like when you were putting those choka cannulas, despite now because the choroidals were there, I would not have gone in a beveled manner and then entered. I would have gone directly perpendicular in, so that the least amount of distance is left in the scleral space, right?
Yes.
Yeah, and I think these two things. Then I have described a test which we now generally do is the endo-illuminator reflex test.
Hmm.
So you just place your endo-illuminator inside the cannula and see the reflex. So if you are getting a white reflex, it means the cannula is in the proper position.
Hmm.
And if you're getting a red reflex, it means there's choroid covering the cannula. So don't proceed with the surgery at that.
True, sir.
I think these few things I would like to highlight.
Yes, sir. Thank you.
Dr. Sangeet has also given us excellent technique of draining the choroidals. I would request him to tell his own innovation that he has received CS Reshme Award last year for.
For draining the choroidals, also this thing worked well. But what I generally use is a controlled cannula drainage technique, which I use a 26 gauge IV catheter, which we used for intravenous injections.
Hmm.
And you just go inside the suprachoroidal space. You just examine whether the tip is inside the proper space or not. And when you do that, you just start withdrawing the metallic stellate and just keep on pushing the plastic tubing inside. So you can even go up to the macula with that, right? And
Yes.
drain the choroidals from that. And another advantage is you can leave that tubing inside because it needs not be observed. Carry on with your surgeries, the choroidals will keep on draining and your surgery will be, so that little amount of choroidal that was left would have drained easily with that.
True, sir. It was my bad day. So I was just trying to finish the surgery. But thank you. I'll keep in mind. So
Thank you very much, Dr. Prathrana, for sharing that case, because not very many people are bold enough to share these cases live in an audience and get the input, and we look forward to